Hi, welcome to part 3 of our lecture on muscles. In this portion, we're going to be taking a look at the muscles of the lower limb, such as the muscle we see here, the adductor brevis. We're going to go ahead and begin here with the iliopsoas, and this is an interesting muscle in that it's really two muscles, what we refer to as the psoas major, which we see over here on the left-hand side of the screen, and the iliacus, which we see on the right-hand side of the screen. Now, of course, we are looking at a patient here, therefore that psoas major is actually on the right side of the body and the iliacus on the left side of the body. But together these form the iliopsoas, having an origin in the iliac fossa for the iliacus portion of this, and on the transverse processes of L1 through L5 for the psoas major portion of this. And the insertion of this is going to be on the lesser trochanter of the femur. Now that's going to help us figure out the action because essentially we want to pull our femur into our abdomen, and that's going to lead to hip flexion. So we would refer to the iliopsoas as a hip flexor. It will flex the hip or the femur. It's also going to provide some lateral rotation and can potentially flex the vertebral column using those muscles when the feet are both on the ground to actually move the torso rather than moving the limbs. So our next muscle then is the sartorius. The sartorius is the longest muscle in the body, sometimes referred to as the tailor's muscle, and we can kind of see why based on the position of this. A tailor would kind of sit in a cross-legged fashion, and this muscle really is going to do that kind of a job. So the origin of this is the anterior superior iliac spine, and we can see that up in here. And it's going to go diagonally across the limb, kind of disappearing here on the medial side of the knee. It is going to insert medial to the tibial tuberosity. Now I want to point out from this perspective how important this muscle is to us for identifying other muscles. What this really does is it separates the iliopsoas and a group of muscles we refer to as the adductors from the TFL or the tensor fasciae latae muscle here, and 3 superficial members of the Quadriceps femoris group. So the sartorius really serves to divide up this lower limb. Now the action of this is incredibly complex, but you can tell essentially by the fact that this is on the anterior portion of the limb, that it's attached to the hip and then down to lower portions of the limb, that it's going to be involved in hip flexion. So flexing the hip, in other words, assisting the iliopsoas, is one of the jobs of the sartorius. But it also does do abduction, and it laterally rotates the femur as well. Not only that, but it can also flex the knee. Now really it's doing this by pulling on the tibia, but when we think about that, we might say we're flexing the crural region because the tibia and fibula are connected to each other. Now I know this motion is complicated, but if you are standing up, all you have to do is put your weight on one limb, and for the other limb, just kind of put it into that kind of crisscross applesauce positioning that you would sit in, and as you pull that limb up to cross it over, you will see all of these motions take place. Our next muscle has a really weird name. It's commonly mispronounced tensor fasciae latae, which actually sounds pretty good. It's correctly pronounced tensor fasciae latae, and that's because those AEs on the end of those words should be pronounced as an E sound. Now, the tensor fasciae latae means that this is the tensor of the fascia lata, which is the connective tissue wrapper around the thigh muscles. So it really is kind of making some sense as far as what its name is. The origin is on the anterior portion of the iliac crest, just posterior to that anterior superior iliac spine, and we can see here where it attaches almost right next to the sartorius. It's going to insert on the lateral tibial epicondyle via something we call the iliotibial tract. Now a tendon can't actually be the insertion point of a muscle. It has to attach to the bone at some point, unless, of course, we are only attaching to superficial tissue, but that's not going to be the case for a large muscle like this. This muscle comes down, blends into this IT band or iliotibial tract, which is a portion of the fascia lata which remains on this dissected individual and is relatively thick. It's going to lead its way down and obviously attach down here to that lateral tibial epicondyle. It's also going to be a pathway for the gluteus maximus, which you can see also blends into this iliotibial tract. Now the motion we're going to get here should be pretty obvious. Because the TFL, which I often like to call it because it's just easier to say, because this is going to originate laterally on the hip, it's going to abduct the femur or abduct the hip, and it's going to provide some medial rotation. The rotations are not always completely intuitive, but anything you can touch on the lateral side of your hips are likely to abduct your femur. Anything we see towards your crotch, this stuff in here, which is going to be medial to that sartorius, those things are going to tend to adduct. So we just kind of want to have a general idea based on the position of a muscle, what it's likely to do. Our next muscle here is the gluteus maximus, and you can see that is the large gluteal muscle. There's also a gluteus medius and a gluteus minimus. Those two are not completely synergistic with this gluteus maximus in humans, so it's important to recognize the gluteus maximus is basically doing its thing, and then the medius and minimus are together working to do something different. So the origin of this is the iliac crest, the dorsal sacrum, and the coccyx, as well as the thoracolumbar fascia and lateral portions of the ilium. Basically, we can kind of find that iliac crest in here and follow this down onto the sacrum right there, and it's going to work its way diagonally across to get to the femur. It's going to attach at its insertion at two locations, the gluteal tuberosity, or we might say this tuberosity named for the muscle, and that's located on the femur proximal to the linea aspera. So it's kind of between the linea aspera and that greater trochanter. And this also attaches to that iliotibial tract, which obviously means that it's going to pull on the tibia. The action of this is actually relatively simple. It's going to extend and laterally rotate the femur. And I highly encourage you to stand up and to extend one limb. That is, you're going to push your femur behind you as if you are running or something like that. And if you reach back and feel your gluteus maximus, you'll see that as you extend and laterally rotate, that gluteus maximus is the primary muscle performing those motions. All right, here we have the gluteus medius, and the first thing we should notice here is that the gluteus maximus has been removed, but it really only covered a little bit of the gluteus medius. The gluteus maximus was kind of in this region here, and we see other muscles in here like the piriformis, and we see the sciatic nerve. Those things were deep to the gluteus maximus, but for the most part, this gluteus medius was anterior to the gluteus maximus. It's really more lateral, whereas the gluteus maximus is more of a posterior muscle. So we say the origin here is the superolateral ilium, and the insertion is going to be on the greater trochanter itself, which we can see right over here. So, of course, we are going to have a minimus deep to it, and we can see that one here as well. So we've kind of removed the medius from a higher location on the ilium, and then this minimus pops up once the medius has been removed. The action here is going to be to abduct and medially rotate the femur. So if we think about the idea of trying to do some kind of abduction of our hip, we're going to involve the gluteus medius, the gluteus minimus, and the tensor fasciae latae in doing that movement. So of course, this gluteus minimus we do recognize as being deep and synergistic, completely synergistic with the gluteus medius. It's almost really like it's just a deep piece of it. They do have separate attachments, they are separate muscles, but they originate on the same area, they insert on the same area. All right, and we can kind of see all of these things here. So we've got our gluteus maximus cut away here, coming across diagonally, and we can see our medius and our minimus here. So you get the idea that we really do have to remove the medius to see the minimus, but we can see a lot of this gluteus medius even if that maximus is in place. All right, our next muscle is one of our adductors. So we will have a bunch of muscles that are working together to adduct the femur and they're all going to have an origin that is somewhat medial, and then they're going to have an insertion that is somewhere on the femur. Maybe it's going to be on the linea aspera, maybe it's going to be near that. We begin with the pectineus, which is not named adductor as most of these adductors are, but in this case, this is kind of our uppermost or most superior of the adductors. It originates on the superior ramus of the pubis, an area actually referred to as the pectineal surface, and then we have the pectineal line of the femur, which is kind of the equivalent of the gluteal tuberosity on the lesser trochanter side. That is, it's in between the lesser trochanter and the linea aspera. The action of this is going to be the same as all of our adductors, with the exception of the gracilis, which is going to rotate in the opposite direction. That kind of means that you really only have to learn this action once, and you can apply it to all of these muscles that we're going to learn here in this little group. So we have adduct, flex, and laterally rotate the femur. And I briefly want to explain that while we're taking a look at this muscle, although again, it's going to be obvious for the adductor longus, for the adductor brevis as well. The adduction is pretty clear. Our origin is medial, our insertion is lateral relative to that. We're going to pull the limb back towards the midline of the body. That's the adduction. Flexion is going to occur because the origin is anterior to the insertion, which is on the posterior side of the femur. We're going to pull that femur forward. That's also going to cause the lateral rotation because we're really pulling on the back of the femur, and the back of the femur is being pulled anteriorly and medially. And that will create that lateral rotation so that our toes end up pointing outward. And again, that will follow for all of the adductors, so we can go through these more quickly. The adductor brevis is a deep muscle. We can't see the pectineus here at this point. We can't see the adductor longus. This will originate on the body and inferior ramus of the pubis, and it will insert on the proximal portion of the linea aspera, giving us the exact same action we've already taken a look at. The key feature of this then is it inserts on the proximal portion of the linea aspera. That is, it is the short adductor. And the reason why that matters is because the adductor longus has kind of the same origin. It's going to be on the pubis below the crest. We could say that's the body of the pubis. It's going to insert on the mid portion of the linea aspera. So it's really further down the femur than the adductor brevis is. And of course, it's going to have the exact same action. So the real key difference here is that we have a brevis on the proximal end. Even more proximal on the femur actually is the pectineus, which doesn't insert on the linea aspera at all, but rather proximal to it. And then we have this mid kind of attachment on the femur for the adductor longus. Then we get into the adductor magnus, which is a really weird one, but if we think about what Magnus means, and we've learned that term before with the foramen magnum, which was the big hole, this adductor magnus is the big adductor. Relatively simple, right? Let's look at this origin. Inferior ramus of the pubis, ramus of the ischium, and the ischial tuberosity. That's like the whole bottom of the pelvis. So that's a pretty big origin. It's a big muscle. The insertion is going to be through two separate heads. The adductor head is going to insert on the entire linea aspera. It's not the proximal portion, it's not the mid portion like the other two adductors, but it's the whole darn thing. Plus, it attaches to the adductor tubercle, which is on the medial epicondyle. Therefore, it has a big insertion and a big origin. Well, it's the adductor magnus. It's the big one. As far as the action, it's almost entirely the same as the other adductors, the pectineus, the adductor brevis, the adductor longus. The difference is it does have a hamstring head, which will help to extend the femur. That is a role that the hamstrings have, and we'll kind of be able to see those in a moment and get an idea of what's going on there, but it will assist the gluteus maximus and the hamstrings in extension. Now there is also another really interesting feature about the adductor magnus. It has within it what we refer to as a hiatus, as does our diaphragm. That's going to be the gap here between the insertion on the linea aspera and the insertion further down the limb on that adductor tubercle. So there's actually a gap in there between those sections of muscle. And you can see that there's something really big going through there. It looks almost like a double-barrel shotgun, which hopefully you don't have poking through your limb, because that would probably hurt. But in this case, this is your femoral artery and femoral vein. And as your femoral artery travels through this hiatus, it becomes the popliteal artery on the distal end. As your popliteal vein comes up from the back of your knee, it becomes the femoral vein. So it's kind of an important transition area there. All right, we do have another adductor, and its name is the gracilis. It's a long strap that runs entirely on the medial side of the thigh from the inferior ramus of the pubis down to the medial portion, or the area medial to the tibial tuberosity. And this is kind of an important and weird attachment site. This area medial to the tibial tuberosity, or what we might refer to as the pes anserinus, is going to have the insertion points, and you can see it really nicely here, for the sartorius, the gracilis, and the semitendinosus muscles. And it's actually referred to as the pes anserinus, or goose foot, as a result of having 3 tendons attached to that area just medial to the tibial tuberosity, the bump that we see there. So the action of this is the same as the other adductors, adduct and flex the femur. The difference is based on its attachment on the anterior side of the tibia as opposed to the posterior side of the femur, where the other adductors attach. This will cause medial rotation. But again, we're going to stick to adduction if you have to think about kind of the main job of this muscle. Now, our next task here is to take a look at the Quadriceps femoris group. The Quadriceps femoris group is going to have a complicated origin because it's really 4 muscles. They're going to originate on things like the anterior inferior iliac spine and various locations on the femur, such as kind of along the neck and on the greater trochanter. What's really important about this group is they have a common insertion on the tibial tuberosity. And that's going to tell us what they're going to do. They're going to move that tibial tuberosity, meaning they're going to move the knee. And because their origins are on this anterior side of the thigh, they are going to essentially straighten out the knee or extend it. So the common action of the Quadriceps femoris group is to extend the knee or to extend the crural region through that attachment on the tibia. Now, one of these, which is going to be the rectus femoris, and we can see that right here in the middle, is also going to flex the hip. So it assists the iliopsoas and the sartorius in hip flexion, and it does that because this is the one that originates on the anterior inferior iliac spine, meaning it crosses the hip joint and the knee joint. The other important thing to know about the quads is we've got 1, 2, 3 of them here. There is one that is deep to the rectus femoris. So we have, in addition to the rectus femoris, meaning the straight muscle on the femur, we have the vastus lateralis, the large muscle on the lateral side, the vastus medialis, the large muscle on the medial side, and deep to the rectus femoris, the vastus intermedius, obviously the large muscle in the middle. And we can see all of those here along with the sartorius to get an idea of how these things are going to shape that anterior side of the thigh. The rectus femoris, of course, is the superficial one. The vastus intermedius is deep to it right along the actual surface of the femur. Vastus lateralis is lateral, having an attachment to that greater trochanter. The vastus medialis is medial, attaching to the neck of the femur. Now, in addition to the Quadriceps femoris group, we have a group that is on the posterior thigh called the hamstring group. The hamstring group, of course, called the hamstrings because people would use the long, skinny tendon of the semitendinosus muscle to hang hams for curing. So what do we have going on with this group? They have a common origin. All 3 of them originate on the ischial tuberosity. Now, the ischial tuberosity is slightly underneath the gluteus maximus, so we can have a little bit of difficulty seeing that. Peel up the gluteus maximus, you can feel the ischial tuberosity and feel all these muscles coming from it. One of them, the short head of the biceps femoris, a 2-headed muscle, right, of the femur, is going to attach to the distal portion of the linea aspera. So we do have a second attachment down below. We do recognize that the biceps femoris will be on the lateral side, and the short head is going to be something we're really only going to see when we start to pull this muscle out away from the bone. The insertions are going to be in 3 different locations because we have 3 different muscles with common origins but different insertions. The biceps femoris inserts on the fibular head. Then we have this attachment posterior to the medial condyle of the tibia. That's going to be for the deep semimembranosus muscle. And then we have the attachment at the pes anserinus, or medial to the tibial tuberosity, for the semitendinosus muscle. So here on the cadaver, we see gluteus maximus coming across to the lateral side. Biceps femoris is on the lateral side. The semimembranosus is deep, forming a trough, kind of like a hot dog bun, so I often refer to this as the bun. And the semitendinosus is this muscle that's kind of skinny coming down here, and it goes through that trough with membranosus on either side of it as it starts to narrow down, so I like to refer to that one as the hot dog. And then it gets this long skinny tendon that goes around to the anterior side to that pes anserinus, and in this case that is, of course, the hamstring. So the action of this group is going to be, given that it attaches down below the knee, but it originates on the pelvis, it's going to cross the hip joint and the knee joint. It will extend and rotate the femur. Now the important thing here is to go with the extend because it depends which muscle you're talking about. The biceps femoris rotates it laterally, being on the lateral side, and the other two, the semimembranosus and semitendinosus, are going to medially rotate the femur. Now all of them cross the knee joint and they will flex the knee. So that's important as well. These both extend the femur or extend the thigh and flex the knee or crural region. And we can see these better here. So here's the attachment on the ischial tuberosity that's common to all of those. Of course, we remember that the adductor magnus also acts as a hamstring as well, and it has attachments on that ischial tuberosity as well as other portions of the ischium. We see the short head of the biceps femoris. We see the long head of the biceps femoris. They join together to attach to the head of the fibula. We see the semitendinosus actually work its way around towards the front of the tibia, whereas the membranosus is kind of wide here and has a shorter, fatter tendon which comes more straight down behind the knee. All right, on to the tibialis anterior. This is the only muscle we're going to take a look at here in lecture that's on the anterior side, although we do also have extensor muscles on the anterior side that we can take a look at maybe in a minute. The tibialis anterior is the most anterior muscle on the tibia. We see that there's a bare bone area of tibia, and if you run your hand off to the lateral side, you will feel this muscle. It originates on the lateral epicondyle and surface of the tibia, as well as the interosseous membrane between the tibia and the fibula. It inserts in kind of a weird location, and it's actually going to share this insertion with another muscle we are learning, so it's important to get this. The medial cuneiform bone, which is one of our tarsals, and the base of the first metatarsal. So that's kind of like the equivalent of our metacarpals, right, which form the palm of our hand. We're dealing with the portion of our foot, the metatarsus, which is formed by those long metatarsal bones. And it's on that first digit. This is actually pretty important as well, and we'll come back to that in a moment. This does this pretty much on the medial portions of this because it comes down over the top and attaches to those bones here. Obviously, we're going to pull that medial side of our foot up towards the anterior side of our tibia. That's going to cause dorsiflexion and inversion of the foot. We're going to bring the plantar surface of the foot medially, bringing that big toe up in the air, and we're also going to bring the entire foot up, causing that dorsiflexion. All right, so here we can see the other anterior crural muscles as well. We can get a great look here at the tibialis anterior with its tendon coming across, attaching basically between that medial cuneiform and the base of that first metatarsal. We also have here an extensor digitorum longus and an extensor hallucis longus. Based on their names, of course, the extensor hallucis longus extends the big toe. The extensor digitorum longus extends the other toes. And of course, there are going to be brevis versions of both of these that are just on the foot. We then have the Fibularis longus, formerly known as the peroneus longus. This is on the lateral side, and this is going to come from the head and proximal shaft of the fibula. This will come down and insert in the same location we were dealing with before, the medial cuneiform and primarily that base of the first metatarsal. This is going to be on the inferior portions of those. So this thing actually comes down and it goes through a notch on the back of the lateral malleolus of the fibula, and that's going to do something very interesting. We're going to get the idea here that when it pulls up, it's going to plantar flex the foot and evert the foot, but we're going to see that a lot better in our next picture. So let's take a look here at this fibularis longus and figure out how it plantar flexes and everts. It comes down the fibula, goes through a little notch in the back of this lateral malleolus, works its way under the foot. So it's coming here from the lateral side, right here by this fifth digit and by this cuboid bone. And it's going to work its way underneath to attach to that base of the first metatarsal primarily. So obviously we're pulling that big toe towards this lateral side of our tibia, but we're doing it from the underside. That's what causes the plantar flexion and then the eversion, making this antagonistic to our tibialis anterior, even though it has the same attachment. It's all about the angle that it goes to get to that attachment. And there's one other really weird thing about this. Imagine for a moment that this was not a foot, that this was your hand. This would grab the base of your thumb, which in that case, of course, would be the base not of your first metatarsal, but the base of your first metacarpal. And as you can see, it would pull that thumb across the palm of your hand, causing you to oppose your thumb. Now, obviously, this doesn't do this in our foot, but our relatives, chimpanzees, gorillas, orangutans, basically any other primates, have the capacity to oppose their big toe. We have musculature to do this. We have the wrong joint there. Rather than having a saddle joint like we have between our carpals and our first metacarpal, we have here a gliding or a planar joint which has little movement and helps stabilize our foot, preventing that opposition even though we have the appropriate musculature for it. All right, we're going to take a look here at the calf then. We have a couple of muscles in the calf. These are big muscles on that posterior side of our tibia and fibula because these are going to be the main muscles for plantar flexion, and that should be pretty obvious just by taking a look at this. The origin for this one is going to be adjacent to the femoral condyles, and obviously that just depends on which side you're on, which condyle you're attached to. The insertion is right down here on a tuberosity of the calcaneus via what we call the tendocalcaneus or the Achilles tendon. So there's a big thick tendon coming down here. You can actually see that the muscle belly ends here and here. This gastrocnemius sometimes has those two pronounced muscle bellies to give this that kind of definition of the calf. And all of this down here below that is tendon coming down, eventually becoming quite thick as it attaches to the calcaneus. Of course, that means we're going to elevate the heel when we contract this, and that is, by definition, plantar flexion. Now, because this also crosses the knee, this can help the hamstring group in flexion of the knee. That's not going to be true for the soleus, which we see here. The soleus attaches to a feature called the soleal line on the posterior tibia, as well as the posterior fibula. It's going to insert in exactly the same location because the tendons of the soleus and gastrocnemius are going to fuse together to form that tendocalcaneus or Achilles tendon. Now, as this does it, it doesn't cross the knee. It will not do anything to the knee. Instead, what it's going to do is only do that plantar flexion. So the soleus is a big, thick, strong plantar flexing muscle. But the gastrocnemius is also relatively large. It's superficial. It gives those two heads to the kind of that definition to the calf, whereas the soleus doesn't really have that two-headed definition. It's a single big chunk of muscle, and of course it is deep to the gastrocnemius. So let's take a look here at the other posterior crural muscles, just kind of for fun. We have a tibialis posterior, which sort of is counter to the tibialis anterior, but again, remember, it's really that fibularis longus, which is the antagonist of it. This one actually helps to kind of hold together the bones that form the arch of the foot. Like we had extensor muscles on the front, we have flexor muscles on the back. This diagram maybe isn't perfect. In general, we're actually going to see that this flexor hallucis longus is a larger muscle. That is, it's fatter, it's more robust. It's involved in flexing the first digit, and that tends to be the most important of our digits. It's the one that we use for kind of pushing off if we're going to get started running. It's the one we use for directional changes, and the flexor hallucis longus tends to be larger as a result of that. We also have a fun muscle up here in the back of the knee called the popliteus. Remember that popliteal refers to the back of the knee. And in this case, it crosses from the lateral side over to the medial side, and it can twist the knee a little bit. This allows us to lock our knees so that we can kind of conserve energy and then use the popliteus here to unlock the knees. All right, so what we didn't really mention as we were going through these muscles is that we do have features, interosseous membranes and the fascia lata, which are serving to compartmentalize these regions. So in the thigh, we have 4 compartments, although to be fair, it's more like 3 across most of the thigh. We have an anterior compartment with things like the quads in it. We have a posterior compartment with the hamstrings in it. We have a medial compartment with the adductors in it. And the lateral compartment through most of the thigh is just going to be the fascia lata, or the kind of thick part of it, the iliotibial tract or the IT band. If we were to get high enough up in the thigh towards that proximal end, we would include the tensor fasciae latae in that lateral compartment. We also have compartments in the crural region. We have 3 of them there. So we have an interosseous membrane between the tibia and the fibula. That's going to separate anterior from posterior. You can see that almost all the muscle mass is in the posterior compartment because we have the very large gastrocnemius as well as the very large soleus, and then the muscles that are deep to those, the flexors and the tibialis posterior. We have our tibialis anterior and extensors in the anterior compartment, and fibularis muscles, the longus, brevis, and even tertius down towards the foot, which are in that lateral compartment. And you might say, why does it really matter that we have compartments? Well, it doesn't unless maybe you have some kind of injury, particularly blunt trauma. This makes me think of kind of medieval warfare where, some people are out there stabbing somebody with a sword and somebody else is out there with a mace just bashing people. Well, if you get that blunt trauma to a limb like this, you're going to cause some internal bleeding. And the thing is that blood doesn't really have anywhere to go. So some kind of crushing injury in a fall, in a car crash, those kind of things cause you to bleed into a compartment. If you do, you're going to start maybe seeing a lack of blood flow to the digits. We refer to that as ischemia. This is the blood starvation as a result of, as you get to that compartment, blood is bleeding out of the tissues. It's pressurizing that compartment because the fascia that is wrapping around it that creates the compartment doesn't stretch, and then you can't provide any fresh blood into that area because of a pressure buildup. If you think back, we've actually learned something very similar to this. Cardiac tamponade was another situation where fluid in between an organ in that case and a sac, which is tough and fibrous, the fibrous pericardium, that was going to create this pressure situation. We're getting the same thing here with what we call compartment syndrome. So how do you deal with compartment syndrome? You do a fasciotomy, a big slice in there. If you've ever watched any kind of medical TV show for very long, you've probably seen a fasciotomy performed because it's one of those things that they like to do on there. It kind of means you've got this area that's really swollen. Somebody brings a scalpel in to slice that, and then there's kind of this splattering because that area was pressurized. So it kind of makes for good TV.